And also this young man. So Zack Held came to us in September. It was a long search to find him. We had to go all the way to the northeast. We can forgive him for that, but he is here. And he's a clinical psychologist. He's a great addition to our team. I hope everyone gets a chance to meet him. I started to take care of CF patients a long time ago. We won't go into how long ago that was. We didn't pay any attention to psychological mental health. It was just not, we were just so focused on trying to keep people alive to get into adulthood. In the last 10 years, it's been realized that we missed a lot. People who have CF and their families have anxiety, have depression, they go through a lot of stuff. And the foundation realized that about 10 years ago and began to really emphasize mental health. Mental health screening we've not been doing that long, maybe 5 years. So we're really grateful. Zack is real well versed in all that, and if you need him, he is here. I may go sit on this couch somewhere.
Thank you very much. Like Shah said, Dr. Zack Held. I've been in clinic since September, and I just kind of want to give a little bit of a presentation on anxiety, depression, kind of my role, and then I'll take some questions if you guys have any questions. All right. So this is kind of what I want to go over. So first I want to talk about anxiety as a whole, and then break it down further into procedural versus long-term anxiety, the differences between those two types of anxiety. I'm going to go over some interventions that we can use specifically for procedural anxiety, also known as situational anxiety, and then interventions for depression, my role again, and questions. And I'm sorry you have to hear my nasally voice. I'm getting over a cold, but excuse me if I cough or anything like that. So I like to start with this quote because I think it's by Dr. Ross Green. I think if we look at mental health and kind of what our kids are going through this lens, it can help us see it as if we just remove some barriers, they can do as well as they want to. So it says, I like to think of kids doing as well as they can instead of doing as well as they want to. So again, if you look at it from that lens, we remove some barriers that are getting in the way and they can do better. So, when we talk about anxiety, I think this slide is really informative because we use the terms anxiety and depression very colloquially. And we say, oh man, I'm worried about everything, I have anxiety, or oh man, like I'm upset, I have depression. And in reality, anxiety and depression can take a lot of different forms. So, someone who is going through PFTs and has anxiety may start sweating a lot, have some muscle tension, have an increased heart rate, and then another person who's going through the same thing could have trouble sleeping the night before, or chest pain, or just overthinking everything. And this is both anxiety, but it comes in two different forms, and I think we have to be aware of that and treat it in similar ways and honor it in the same way. Because everyone experiences anxiety differently. Okay. So, like I said, if we break up anxiety into procedural anxiety or situational anxiety, and then long-term anxiety, leading into possible adjustment issues, there are kind of distinct differences. So for procedural anxiety, for our purposes, we can define it as an excessive fear of medical procedures that results in distress or interference with completing that procedure. And the anxiety can occur either prior to or during the procedure, and oftentimes will take the form of panic attacks. If your child, or if you've seen a child ever get really, really anxious about something like blood draws or any sort of procedure, that is procedural anxiety. It's also known as state anxiety, and this is an important distinction between procedural anxiety and long-term anxiety. State anxiety just refers to it's anxiety that you have because of a situation. So trait anxiety, which is long-term anxiety, is what we talk about when we think of like a genetic predisposition to anxiety. It's someone who doesn't have anxiety is down here, someone with trait anxiety is just consistently at a level up here. And they're just going to be kind of at a low level of anxiety at all times. This is the type of anxiety that can lead to a generalized anxiety diagnosis, can kind of lead into depression or an adjustment disorder. And trait anxiety and state anxiety are very related. So if someone has trait anxiety, they are probably more likely to experience state anxiety or situational anxiety because they're already up here. So anything that kind of brings them a little higher is going to set them over the edge. That being said, trait anxiety is much more prevalent in chronic illness populations than kind of the general population, specifically in cystic fibrosis. It's about 2 to 3 times more prevalent. So if we think about the last slide, where if we have trait anxiety, we're more likely to have anxious reactions or panic attacks across situations, it makes sense why kids have anxious reactions. There are a bunch of reasons why anxiety is more prevalent in chronic illness, but I want to focus on the 3 in red here. The first is illness uncertainty, which refers to every time you come to the hospital, you don't know what you're going to be told about your illness. You could be told that the treatment's not working and you're going to have to try something else, which could be anxiety provoking. You could be told that it's progressed and we need to do something more severe that could have different side effects. You're always in this state of what happens next, what happens next, what happens next, and this can lead to anxiety. The next is medical trauma, and there's been a lot of research on this in the past few years. And basically medical trauma is this idea that every time you come to the hospital, every time there's a procedure that maybe doesn't go that well, or you come to the hospital and you're put in the same room for your clinic that maybe you were diagnosed in, these are all small traumas that add up over time that lead to a PTSD-type anxiety response. And the last one I want to focus on is just the hospitalization over and over and over again. And I know this is anxiety-provoking for everyone. Parents, kids, extended family. Specifically for kids, it can cause a lot of anxiety because it's a disruption in their kind of normal life flow, and we'll go over this a little more later. But the idea that they're seeing their friends experience these things, they're thinking about all the things that they're missing in school, thinking about how they have to catch up when they get back. So even when they're back in school, they're going to miss a lot of things that their friends are doing because they're going to have to catch up on schoolwork. So these are kind of the 3 things that I see as the most universal across kids with CF that cause anxiety. However, and I'll explain why there's a picture of this in a second, anxiety can also sometimes be functional. When we think about anxiety, we have to think about both the level of anxiety and the duration of anxiety. So, on the left, with the peak of like the worst mountain ever of stress, it's called the Yerkes-Dodson law of anxiety. And basically, it's like the worst version of Goldilocks and the 3 Bears you've ever heard. It says you can have too little anxiety, too much anxiety, or just enough anxiety. Too little anxiety, if we use the example of someone who's trying to get all their treatments in, would be someone who doesn't really care about their treatment, kind of does it sometimes, kind of does it another time. There's no anxiety really spurring them to do their treatment on time or at all. Someone who has too much anxiety really does their treatment to the letter of the law, to the T. If they're 5 minutes late, if they miss one treatment, it's the end of the world. They're calling the hospital, they're wondering whether they should be admitted. Right in the middle is someone who has anxiety saying, okay, like this is important, this matters to me, I'm going to do it to the best of my ability, I'm going to make it a priority, but there's an understanding that things sometimes get in the way, maybe I do my treatment a couple hours late sometimes, it's okay. Then this, which I know you're all wondering about, is from a book called Why Don't Zebras Get Ulcers? And the basic idea of the book is zebras should be the most stressed out animals in the animal kingdom. They're constantly just getting chased by lions. Basically their entire job in life is to avoid getting eaten. However, they do not have the same stress response that humans have. And it's because once they have this fight or flight response to avoid getting eaten by a lion, once the lion is gone, they're good. They're grazing in the grass, they're not thinking about it anymore, they're totally fine. Humans, when they activate a fight or flight response, it just stays. Because we think about it, we think about it, we think about it. We think about the things we could have done differently, we think about the things we're going to do next time. If it comes up again, we just ruminate, and we prolong this stress experience. So when we think about stress, we don't want to say, you shouldn't be anxious, you shouldn't be stressed. Why are you anxious about that? Why are you stressed about that? We want to think about what is the level of stress and how do we decrease that level, and what is the duration of stress and how do we make it so you're only stressed when it's appropriate to be stressed and you're not just stressed continually. The way that we can do that as therapists and mental health professionals and as parents is we can kind of lean into our child's developmental milestones. So for adolescents and young adults, when we think about adolescence and we think about what's going on in adolescence and what adolescents want, the thing that comes to my mind is independence and taking control over their treatment and kind of moving away from relying on their parents. So we can give them that to a certain extent. That's part of why we do CF Rise. And we want to encourage them to take control of their treatment, take ownership of their treatment, encourage them to ask questions, share any concerns. We can give them choices. So if you as parents say, okay, I can come to clinic at 9 or 10 and those are both options, doesn't really impact me, we can give our kids that option. What would you prefer to do? We can give them choices within the broader choices that they don't have to give them a sense of ownership. For children, younger children, for me, I'm thinking under 11, when we think about where they are developmentally, we have to think about how they interpret their world. So most of the time for kids, it's school, home, school, home. So parents and teachers are going to be the most important people in their lives. And then when we introduce hospitalizations and doctors and clinic visits and missing out on things with their friends, that can be problematic for them. And what happens is because they're younger, they don't have the language to express their feelings, and it comes out as behaviors. So typically, I'm angry, I'm going to hit something, I'm going to yell, I'm going to scream, I'm going to do all these things. There are some gender differences. Boys typically act out more, girls are typically more internalizing, but it's more behavior instead of words for younger kids. So, on that note, we can talk about some interventions we can do for anxiety and procedures that kind of hit on some of those behaviors that we see from younger kids. So, for younger kids, again, we have aggression and tantrums with anxiety and procedural anxiety in particular, and typically the feelings behind those are fear, anxiety, and helplessness, and that's kind of what leads to these behaviors. What we can do is we can do interventions that help them figure out names that they can give to those emotions. So, can you think of a time when you were upset? Can you think of a time when you were angry? What did that feel like in your body? Was your face warm? Were you clenching your fist? Did your stomach hurt? If they say yes to all these things, you can say, okay, when you're here in clinic, what does it feel like in your body? Oh, your face hurts, you're clenching your fist, your stomach hurts. Is it possible that you are angry? Yes, and then we ask them to use those words the next time they come to clinic, or the next time they do a procedure. Some disclaimer that I always like to give parents is that kids will always displace this behavior and feelings onto their primary caregiver. So if you are in clinic and your kid is very angry, you are probably going to get the brunt of it because you are a safe person. They know that they can act out, be aggressive, do whatever they want to do to express their emotions, and you will still love them, you will still be there for them. You are their safe person. So, I always like to warn parents, when we start to do interventions, it typically gets worse before it gets better, and it will always probably be the primary caregiver because you're their safe person. In terms of adolescents, we can do a little bit of different strategy because for adolescents, their behaviors are different. So for adolescents, it's typically a lack of cooperation or withdrawal from sharing their feelings. And what we want to do is kind of, again, give them that control back, because for adolescents, lack of control equals anxiety. And again, when you think about adolescents, you think about how peers become the most important part of their lives around 14, 15, 16, and we're taking them out of that group of friends when they're hospitalized and when they're going to clinic and things like that. So when that anxiety increases, their feelings of helplessness result, which can result in a lack of cooperation. So again, we want to give them this illusion of control. We can give them choices within the broader choice, and also give them choices in coping. I know this is something that you struggle with, or I know this is something that is hard for you. What do you want to do? Do you want to play on your iPad? Do you want to Skype with a friend? What do you want to do? And you can use that coping skill to get through the situation. From a parent perspective, I know this is a little counterintuitive, but there have been a lot of studies on how to best support kids during procedures, during hospitalizations. And they found that excessive reassurance, if a kid asks you, is it going to be okay, is it going to be okay, and you say, yes, it's going to be fine, it's going to be fine, actually increases a child's distress. What we can do instead is we can work with that child to give them coping skills that they can practice even when they're not anxious and not stressed and feel like they have some sort of mastery over those skills. And we can ask them to use those in situations where they're anxious. So if a kid says, will this blood test hurt? We can say, I don't know, but I know that you can use this coping skill. I know that you can get through it. And then when they do get through it, they'll chalk up the fact that they got through it to the coping skill and not to the fact that you reassured them. The goal is to get them to think about using a coping skill instead of asking for reassurance when they are stressed. So shifting gears a little bit to depression, because this is another issue for mental health for kids with CF. These are the symptoms of depression. To be diagnosed with an official depressive disorder, you need 5 of these symptoms for a period of 2 or more weeks, every day for most of the day. So depressed mood, lack of pleasure, change in appetite, change in sleep, fatigue or loss of energy, feelings of worthlessness, poor concentration, thoughts of death or self-harm. You can be depressed and not meet all the symptoms required for an official diagnosis, or meet all the symptoms and only meet them for a week and a half, and still feel depressed and still be depressed. Just because you don't get an official diagnosis doesn't mean that you're not struggling. And that is what I try and tell kids a lot, is that it's not, you don't need a diagnosis to get services, to see me, to feel like you are depressed. Again, depression is more prevalent in chronic illness and CF, and there's for a number of reasons. I want to focus again on the 3 there in red. The first is social isolation. So when you're in a hospital for 2 weeks and you're missing a lot of things that your friends are going through, not to mention the fact that you can't really physically be in the room with another kid with CF, it's really hard. It's also hard on parents when they have to miss work, and that whole kind of web of stress in the hospital room can be difficult sometimes. There's also a large burden of care, as I'm sure you all know. On average, 2 to 4 hours of treatment for a CF kid every day. If we just play that out, if you get out of school at 3 o'clock and you have 2 hours of homework, which at least when I was in school was a conservative estimate of how much homework I had, and then you have dinner with the family, we're talking like 8 o'clock at the earliest by the time you're done with treatment, and then that's pretty much your entire night. So that's a huge burden of care on both the kids saying, okay, I can't really do extracurricular activities because I have to do my treatment, and the parents saying, okay, as soon as I have to get home, to make sure my kid does their homework and does their treatment before I can even think about doing anything for myself. And then again, tying this into the one of the larger issues, which I think is school or work problem. So if a kid is consistently missing school, or worried about getting their schoolwork done and also getting their treatment in, and they're constantly in this sense of catching up, or I'm missing out on things that my friends are doing, it's going to cause a lot of stress and a lot of feelings of depression and feeling like you just can't get ahead or get your head above water. So all these tied together, there is a huge burden to help your kids catch up in school if they're in the hospital. There's a huge burden to help them do their treatment. There's a huge burden on the kids to get all these things done. And it only gets more of a burden as they get older and go through high school and college and all these things. So what can we do? So again, for younger kids, typically we see behaviors as a result of depressive symptoms. And what we can do is we can validate these emotions and feelings without accepting these behaviors. So So I'm sure you've heard someone at some point in mental health say you can't argue with a feeling. All feelings are valid. You can be sad, you can be angry, you can be upset. Doesn't matter why, that's just how you feel. We can validate that feeling without validating the behavior. So if a kid is angry or scared and hits someone, typically it's their sibling, we can say, okay, I understand you're angry or sad, suggest something they can do instead of that behavior, but we can still implement a consequence for the behavior. So you need to go to your room for 30 minutes because you hit your sister. You can say this punishment is being given because of the behavior, and be really clear that it's okay to have that feeling, but the behavior is unacceptable. This is basically me and my brother. For older kids, the kind of standard treatment is called cognitive behavior therapy. And it's really this kind of circle of thoughts, emotions, and behaviors and how they interact with each other. And I think this is a really good example. So if someone is feeling unsupported, angry, and lonely, and they have a thought of, because of this feeling, that I can't rely on my partner, and then they have the behavior of when my partner tries to help me, I turn away, this is going to turn into a circle. They turn away from their partner, they feel more unsupported, angry, and lonely. Then they have this thought, then they have this behavior again, it just goes around and around and around. So what we try and do with kids in cognitive behavior therapy is, again, you can't argue with a feeling. But what we can do is we can try and insert ourselves to keep them from doing this behavior, or insert ourselves to challenge this thought they're having, and try and break this cycle. So when we focus on ways to challenge thoughts and change behaviors, sometimes we can get them to either do a different behavior or look at the facts of the situation and say, actually, my partner's really reaching out, and I'm just saying no, no, no all the time. Maybe if I say yes, I would be able to rely on that partner. And these irrational thoughts are called thinking traps. And so if you hear your kid talking about thinking traps or irrational thoughts, we are just talking about ways that we can examine the evidence and think about other possible reasons why we're having these feelings. And there are differences for developmental stages. Some of these thoughts are developmentally appropriate. For teenagers, thinking that everyone is watching them and everything they do matters is developmentally appropriate. Thinking that, their friend is mad at them because they wore the same shirt as they did is developmentally appropriate. There's this, so we have to take into account developmental stage when we're doing this type of therapy. The other type of therapy that's a good standard of care is relaxation and mindfulness. I'm a big fan of this. I think it's gained a lot of steam over the past couple of years. It's basically the opposite of automatic pilot mode. It's trying to experience the world in the here and now, in the present, being very cognizant of what's going on around you. So, we don't want to think about the past, we don't want to think about the future, we want to think about right now. The kind of common visualization that's used is if you think about your thoughts as leaves on the stream, and they're just floating down the stream, you don't want to be that person that just runs into the stream, grabs on the leaves, and just stares at them and examines them. You just want to watch your thoughts float by. You can acknowledge that they're there, but you watch them float by and focus on what you're doing. The key to this, and I think this is really hard for a lot of kids, but it can be really useful, is trying to take a non-judgmental stance. And what that basically means is we're not going to take that next step and think about what something means. The example I give kids is if you get like a D on a test, you can say, oh man, I got a D on a test, this means that I'm stupid, or this means that I'm horrible at math. Or you can say, I didn't study and I got a D on a test, and then stop. Don't make a judgment. Don't make any meaning of it. It doesn't mean anything. You got a D on a test. That's the only thing that happened. That's the fact. So we try and get kids to stick to the fact and not make a judgment. All right, finally, and then I'll get to my role and take some questions if we have time, or I can answer questions at the very, very end. Chronic illnesses and having a child with chronic illness the child with chronic illness is most likely going to become the center of family's attention. It's just kind of how it is. There's a lot of things that go into having a kid with chronic illness. And this can result in siblings acting out and having their own challenges. So for younger siblings, there's challenges with them not understanding the disease or the seriousness of it. And what can result is this idea that any attention is good attention. So I'm going to act out to get attention from mom or dad. I'm going to scream every time they leave. I'm going to do these things because I just want attention. For older siblings, there's oftentimes anxiety and depression once you kind of realize what the disease means and the things that your sibling can and can't do. There can also be a desire to help to an extreme degree. So kind of taking on almost another parent role. Like I'm going to help do this and help do that, and drive to this and drive to that, so that they kind of miss out on their own childhood. So keeping in mind how siblings are doing and family as a whole is another big part of it. And so these are a lot of ways that a psychologist or a therapist can help. I think one of the biggest things on here for me is normalizing concerns and providing guidance. I think a lot of times kids with CF, just because of the nature of the disease, don't know a lot of other kids with CF or don't interact with a lot of other kids with CF, so kind of normalizing their concerns, normalizing things they're thinking about, and helping them think about their future and goals and how to achieve those within the context of being healthy and doing their treatment and doing all the things they need to do, I think is one of the biggest things that I can do. But really, I'm happy to see anyone that feels like they need it. So. Any questions?
Next, we're going to have Auburn, a patient in the adult program, and her mom. They're going to talk about their experience with CF, their story, that kind of thing, okay?
Hey, my name is Auburn Stevens. I just turned 30 years old.
Auburn, will you move to this? Do you mind standing in the center? Thank you.
I just turned 30 years old, which when I was 15, the Bucket List movie came out, and my bucket list was make it to 30. It pissed her off to no end because she wanted me obviously longer, but for my 30th birthday, we had a huge bucket list party. I crossed off make it to 30, and it was huge. I think we had like 90 people at the house. It was a lot of fun. But so I'm not going to go like way deep into my whole history. It's long, but I'll give you kind of a little clip of it. I was diagnosed with CF at 2.5 years old. At that point, I had pneumonia from the day I was born until diagnosis. So at 4 years old, they removed part of my lung, my left upper lobe, just from infection. It just didn't work anymore. It was causing the rest of my lung to get infected. And then at age 6, I had a blockage, intestinal blockage, and I had most of my large intestine removed, as well as my descending colon. Just enough where I didn't have to get a colostomy bag or anything, but that was a pretty major surgery then. And then my last major surgery was at 12. I had a second part of my left lobe removed, the middle lobe. They had thought about taking it out when I was 4, but decided let's try and keep and hold on to it another couple years. But after, I felt like I was a pretty normal kid.
But why did that happen? Why did you have to have your lung taken? That second piece.
So I was a graduate girl, I guess. I was really bad about doing my treatments. I fought them all the time about doing treatment. So I went probably 2 years without doing vest at all. And so that just got worse and worse and worse, and finally I had to come out. The day I got out of the hospital from that lung removal, from that day forward, I never missed another treatment in my entire life. I would go to college, I was in college, I would go to parties, get home at 3 a.m. and strap on that vest. I realized, well, I guess they work. Who knew? Yeah. So yeah, I finished high school, I went to college, I did everything a normal person would do, Joined a sorority, went to parties, in high school I was a cheerleader. I really tried not to let CF get in the way of my everyday life. I tried to schedule my tune-ups around school breaks. Spring breaks I'd spend hospital, summer, Christmas break, that was kind of my go-to for hospital stays. And then I finally convinced my doctor to just let me do IVs for the majority of it, especially when I got kicked out of the kids ward. There was no PlayStations or anything, it wasn't as fun. But yeah, so when I graduated college, I was pretty steady lung function-wise. I was around like 35% lung function. Still just living like a normal person. I got married about 6 years ago. and my goal for getting married was to walk down the aisle and not have a cough attack. And so I went to rehab every day for 3 weeks and got my lung function up enough where I was able to walk down the aisle without having a cough attack and not embarrass myself in front of all my friends and family. And I mean, that was a huge goal for me. But 2 years after that, my lung function was around 22%, and I got an infection. It was just hovering around 20, and my doctor said, I think it's time we talk to Duke. So they sent me to Duke University in October 3 years ago. I had a double lung transplant, and it's been amazing. I mean, it's a miracle, really. It's not a cure, obviously. I still have cystic fibrosis. It's in my genes. I have it in my stomach, my sinuses. I go once a month to the ENT. But I can breathe. I work out 3 to 4 days a week.
She dances, she laughs.
Yeah,
I mean, she wasn't doing that pre-transplant.
Yeah, it's
She
crazy.
had gotten, like, you talk about depression, she was definitely depressed. I mean,
Yeah.
she was in bed, her and her husband had their own place, and she got to a point where she was in bed 24/7. And they moved back home with us, because he was traveling and she couldn't stay alone. And so they still live with us. I won't let them leave now, I'm spoiled.
I mean, he was worried leaving me alone when I was on oxygen because in the middle of the night I stopped breathing and he had to shake me to wake me up to make sure I got to breathe again. But going back to the mental illness part about growing up with CF, I always had depression. I remember at 10 years old I was writing in my diary and I wrote a pro and con list of why I should stay alive. Like, why should I be in this world? Because I felt like such a burden on my parents. Like, they had to miss work to come to the doctor's offices with me. My sister had to spend Christmas in the hospital. Like, it's not fun. I have so many pictures of me in the hospital in my little gown, and my sister's like all dressed up in her little frilly dresses and a big bow for like holidays, and that's how we did it. And I remember all the time feeling like if I wasn't here, my family would be so much better off. I mean, they could live so normal. And it wasn't until I was about 15 or 16, mental health wasn't talked about 20 years ago. It wasn't brought up. So my mom finally was like, let's go to a therapist, let's talk about it. And I talked about it, and finally I moved up to adult CF doctor, and he asked about my mental health, and that was 12, 13 years ago. And he decided, you definitely need to be on an antidepressant. And that was the best decision I ever made, going from like sleeping all day to constantly thinking about death, like when am I gonna die? There's always that timeline. To finally just being like, when it comes in, I'm just gonna live my best life I can live. Especially now after transplant, like I said, it's not a cure. I take anti-rejection meds, and I've been through rejection once. I've seen dozens of friends pass away. I've been to 3 funerals this year of people who've had transplants. So, that's always in the back of my mind. But now I know, I live, like I said, for today. I leave for Scotland in a week. We're just having the time of our lives. And I think going to therapy and like seeing a psychologist and stuff like that really put me on that path to definitely stop thinking about the negatives of CF and what I can't do with CF and what I can do either because of CF or in spite of. So.
And because of it, you've helped a lot of other people with CF, a lot of younger kids, people your age, just having those conversations. So, again, it's about what you can do today.
And also, you were saying there's not a lot of like contact with other CF patients. When I was, first getting in with the CF community, I had a pen pal who had CF because there was no social media, there was no Facebook Messenger, Instagram, and stuff like that. Now I have best friends who have CF and who have had transplants who I've met over Instagram. So there's a lot, it's a lot better now that, your kids are growing up. Social media is terrible. There's also a great blessing also because you're not isolated. I honestly thought I was the only person with CF for the longest time. I didn't know other people had it.
Well, when you were real little, they used to do a support group when we lived in Virginia, and we would take all of our kids and bring them all into one room because we didn't know, doctors didn't know that,
that was
not a good
before
thing.
the protocol.
Yeah, exactly. So, at that point, you got to spend time with your parents. What you guys have here is awesome. The fact that you guys have each other, use this opportunity to get to know each other and call each other, and, build relationships with people because you're all in the same boat. As a parent, when she was going through transplant, people would say, how's Auburn? I'd break out and start crying, and it was the hardest time of my life. I couldn't say her name without crying. So I went to my doctor and I'm like, I think I need help, like I'm falling apart. So they put me on an antidepressant. And since then I'm like, can I come off? And they're like, no, because you have PTSD. I mean, this is a lifelong thing for you. I mean, there's always gonna be ups and downs, and there are. You know, when she gets sick, I start thinking about rejection and, you know, what can happen. And, you know, your mind goes to other places. And they said, just stay on it. You're in a happy place. This is good. So, you know, think about that for yourselves. I mean, it worked for me. I don't know, you know, talk to your doctor.
And you have to take care of yourself before you can take care of your kids, for sure. I remember when she was breaking down, my husband, we lived in Durham for 6 months while I was getting my transplant. And my husband literally had to go to her and be like, stop. He yelled at her and was like, get with it, you need to, like, Auburn needs you.
Yeah. I mean, I had a breakdown and, you know, I just felt like, well, she doesn't need me anymore. She's going to be healthy and I've done my job and it's over for me. And I got under the covers and I was just, you know, like a child, I covered my head up and I was like, this is it, I'm done. And he literally came in and shook me and said, get out of this bed. She needs you more now than ever. So, you know, your kids will always need you. And then as far as siblings, now her sister, you know, you talked about depression in siblings, and, you know, some siblings feel like they have to be another parent. She struggled as well, and so I put her in therapy, because I didn't want, when she became older and a young adult, to look at me and say, well, you did this, and you didn't spend as much time with me, and woulda, coulda, shoulda. I wanted to nip it right there, and if she had emotions that she needed to share, that she could share it with a third party. So, and she's also on an antidepressant. And I got my husband on one. We're all good. Everybody's happy in our house. I'd say better living through chemistry.
Yeah, my sister's like the opposite of me, healthy as a horse. Like, she cries when she's to get a shot. Or I go get blood work once a week, like, no issue, so.
Now, even growing up, I mean, I always felt like with CF, you know, she'd wake up with 103 fever. And I'd be like, go to school, Buttercup. You know, this is your life. I mean, when you get a job, you can't call in sick because you don't feel good because you have a cough. I mean, this is your life. Accept it, deal with it, go to school. And she'd say, you know, I went to school and I threw up all over myself, but you know what? I wiped myself off and I went back to class because I knew if I called you, you weren't coming anyways.
Yeah, I literally, it was exam week and I puked all over myself, like, from coughing so hard. And I called my mom, she brought me a change of clothes, and that was it. And she's, good luck.
Yeah, I mean,
And that's how, yeah. I never skipped, I mean, college classes, I went to most of them. You know.
her sister would wake up and say, I have cramps. I'd be like, stay in bed. You know, I can't deal with you. Like, you're fine, you miss a day. But her, I was like, this is your life, get used to it. You know, you gotta be tough. So.
Yeah. I mean, it's definitely, I mean, it's made me tough.
And we're getting on an airplane.
I have to say, I was telling someone driving in here, pulling into the parking deck. It's been like 4 years since I've stayed here. And I was like getting sweaty and shaky, getting anxious, like, oh God. Like, last time I was here, I was in the hospital, like, getting sick, and I don't even know. So yeah, it stays with you, that PTSD of things that happen here.
Yeah, we're getting on an airplane in a week and everybody keeps saying to her, you sure you want to go to Scotland? I mean, people are sick, the coronavirus, and she's like, yep, I'm going. I've got to live every day. So, any questions? No?
If you think of anything, I'm here.
Yeah.
You can find me on Facebook or whatever, yeah.
Yeah, always on Facebook. You know, again, like I said, you guys are really lucky that you have this group, and, you know, make friends and get to know people, and, you know, use the resources. They help. Okay, thank you.